Perfect. Let me share my screen again. Can you see now my presentation?
Yes, definitely.
Perfect. So yeah, I would like to focus especially on lifetime management on today's talk. And as you mentioned earlier, as the TAVR expands to lower ages and low STS scores, as you can see here over the years, first of all, the number of TAVRs has exploded. The number of surgical AVRs is slowly declining, but we can see that the age and the STS score has been going down for patients who are undergoing TAVR. These are some comparison of the previous guidelines between the European and the American societies of cardiology. There are some differences, there are some gray zones, as you can appreciate here. And according to the updated European guidelines, of course, the age cutoff for TAVI now is down to 70 years for patients with tricuspid aortic valve stenosis. And of course, we need to take into account several factors, not only the age. There are certain factors that favor surgical aortic valve replacement, even for older patients than 70. For example, a very severely calcified annulus or LVOT, bicuspid valve with challenging anatomy, a very small annulus, risk for coronary obstruction, and of course, there are certain factors that favor TAVI for older patients, as you can see here. So for younger and low-risk patients, we need to make sure that we optimize the TAVR as much as possible, because any suboptimal outcomes on these patients will impact a lot their life expectancy and quality of life. And we need to take into account all the major issues or complications after TAVI. For example, the patient-prosthesis mismatch, the paravalvular leak, valve durability, coronary reaccess, and of course, conduction disturbances and need for a pacemaker. This was a nice study that showed how the effective aortic valve orifice area decreases after every valve-in-valve we do, and how patients can easily end up with patient-prosthesis mismatch if they need like 2 or 3 valves during their lifetime. So it's very important to plan ahead of time before we place the first valve in, and make sure that these patients have, especially when they have 20 years ahead of them, we can give them a good result. So, and of course, we need to take into account that doing TAVR for younger, low-risk patients, that if this TAVR valve needs to be explanted surgically, this is not ideal. We know that from big registries that the morbidity and mortality of TAVR explant is relatively high and probably unacceptable, especially for younger patients. So we should better avoid that. So here comes the AI to help us and to add an additional layer of understanding and planning during TAVI. In the United States and the University of Miami, we use Dardas simulations, which is very similar to FIOPS you have in Europe. And you can simulate different types of valves, like SAPIEN in SAPIEN, Evolut in SAPIEN, Evolut in Evolut. I think they will have a platform for Navitor very soon as well. So I'll go to a case just to give you an example. So we have a 71-year-old male, otherwise healthy, no other significant comorbidities, with severe AS, low surgical risk, STS was about 1.5%. But the patient did not want to have surgery, did not want to have surgical aortic valve replacement. So you can see the valve is very calcified and the annulus is very elliptical. What's good for him is that the annulus is large, so at least we can place a large valve, and the coronary heights are adequate, more than adequate for a TAVR procedure. So we simulated a 29 millimeter SAPIEN 3 valve, and that's a 360-degree view. There's no significant annular calcification. The main calcification is the leaflets. And you can see how after valve deployment, there is adequate distance from the coronaries for future valve-in-valve.
Nico, can you prescribe what the color green, for instance,
yes, of course.
specifies? So it's like a calcification or what it is?
Oh, yeah, let me tell you. Yeah, so the green, so the different colors, green, blue, and red is the leaflets, and yellow actually is the calcification here. So yellow is the calcification, and the different leaflets are with different colors like blue, green, and the one on this side. So yellow is the calcification, and the red, right here. So then we assess, of course, the distance from the left coronary, and they have this index here. We divide the distance from the leaflet to the top of the coronary sign, the aortic sinus, and we divide that by the ostium of the left main. They found in their models that a ratio less than 0.7 is considered high risk for coronary obstruction. But in this case, you can see there is adequate distance, the sinus is large, and you can see that even if you do a valve-in-valve in the future, you will not risk coronary obstruction or sinus sequestration even. So this model also can predict paravalvular leak. First of all, they visually measure any gaps they see. So here they see a gap of about 1.6 millimeters, which is actually fine. They say up to 1.5 millimeters usually fine because this model doesn't take into account the outer skirt yet. But here you can see they give this flow trajectories here. So there is a possibility for a mild, very, very trace paravalvular leak around this commissure. Those red lines right here predict the flow, the backward flow, a paravalvular leak. So this is the SAPIEN valve, and then we simulated the 34 millimeter Evolute FX Plus valve, and of course there's still adequate space in the sinus and adequate space from the coronary. The issue here was the ellipticity of the annulus, very elliptical annulus, and the model predicted significant gaps, especially around the commissures after valve deployment, which would lead to almost circumferential paravalvular leak. Of course, we can always post-dilate to optimize, but we would like to avoid as much as possible post-dilating the valves. So given these findings, I decided to we also simulated for future purposes, just because we can practice that, we can do that. The 26 SAPIEN in a 34 Evolute, in case we place a 34 first, and you can see how there's zero risk for coronary obstruction. So we ended up deploying a 29 millimeter SAPIEN 3, which looks like appropriately sized for the annulus. There's no significant paravalvular leak, as you can appreciate in the aortogram. And the patient did very well. So one of the new features of this AI model is also a prediction of gradient after TAVR. There was this publication, which was published the end of last year. And in this particular case, the model predicted a mean gradient of 6, a peak gradient of 12, based on the patient's anatomy and valve size. And the post-TAVR echo showed a mean gradient of 6, actually, which was very the same as predicted, but a peak gradient of 11. I guess we can accept this one point difference. So very quickly, just a second case that was a little more challenging, aortic root anatomy because of low coronary height, a little less than 8 millimeters, small annulus, and STJ calcification right here. The length of the left coronary leaflet, they measured it around 12.9. but the sinuses were adequate, around 30 millimeters. So I was less worried about coronary obstruction in this case. We simulated this 23 Sapien 3 valve first, and you see there is, of course, less space than the previous case, but the ratio is 2.9, so it's more than 0.7, and there is adequate distance. Even if we want to do a valve in the future, it seems that we will cover this, but there is still adequate space to fill the coronary there. We simulated also 26 self-expanding valve. You can see the ratio here is lower. It's 1.7 now. There's, of course, smaller space in that area now, the opening. And there was this STJ calcification that I was a little concerned that if the patient needs a future valve in valve, this space there may be an issue. So those case ended up placing a 23 millimeter Sapien. And you can appreciate here the STJ calcification before the contrast injection. It's a very good result, good coronary flow, and no significant paravalvular leak. So a few closing points. Now AI simulation is the present, and of course the future. Although we can get the majority of the information, most of the information from the CT. I think that AI and the 3D modeling adds an additional layer of understanding and assists with future planning. It helps with individualized patient care and optimization of outcomes. Of course, we need more like long-term data and ideally randomized prospective data. But the use of AI platforms for structural heart interventions. Of course, there's continuous improvement of the models. And now one project I've been working on with DAS is try to predict the commissural alignment of the Sapien valve, because we know that the alignment can be very unpredictable. But now it's a project now that we've been working for almost a year, and I may be able to present some results next time. I would like to thank you again for your attention, and I'll be happy to take any questions.
Thank you, Nico. And any questions from the audience or from Petros Dardas? Okay. Nico, in the meantime, do you think that do you do the DAS simulation in what percentage of patient, and for which patient you think it's worthwhile?
Yeah. So now. Yeah, we're doing almost for every patient because we're building a registry. But initially, we started mainly with patients that would have some anatomical concern, either small annulus, low coronary height, small sinuses, and very elliptical annulus or very calcified annulus. One other feature I didn't show you today is it predicts the annular stretch if you have significant annular calcification, and that can the use cases of annular rupture to make this model. So obviously this is not as perfect as the other features of the model, but when I'm worried about an anatomical feature of the patient or a specific complication, I usually use the DAS.
Yes, and Dr. Halapas, Antoni, you have a question?
Great presentation. Just a short question is, in which percentage do you change your strategy based on the data that you get from these simulation systems?
Yeah, that's a great question. Actually, that's one. That's part of the registry we're building right now. Once we have a good number of patients, we're planning to analyze and see how this changes our prediction. So I would say rarely. It's mainly sometimes it changes. The sizing of the valve doesn't change. The type of the valve a few times changes. But I would say the minority of the cases, we have to make a change. But it's mainly the type of the valve. and it's a minority, but still, I think a minority, if we do TAVR for younger patients, is still important. Again, I'll have a more specific answer to your question when we reach a certain number in this registry and we analyze and have the results.
Okay, Nico, thank you so much. Have a great day.
Thank you.
And we have
You
to leave
too.
it there. So.